Okay, hello. Good afternoon. Buenos tardes for the international folks. My name is Shahed Ghoghawala. Thank you for having me. I'll be talking about MicroPulseTransscleral laser therapy for glaucoma management and a little bit about myself. Let's see. Oh, yeah, that's right. You told me that already. There we go. So I'm a small community comprehensive ophthalmologist. I actually did a cornea fellowship with the late, great Roger Steinert, but I have so many Medicare and Medicare replacement plan patients that I have to take care of a lot of glaucoma. And as a disclosure, this talk is sponsored by Iridex. So glaucoma, of course, we always start with eye drops, and there are so many issues with the eye drops that we all know about. Sometimes they're effective, but maybe we don't have, maybe we haven't achieved our target pressure, so we add more drops. We add a drop, and sometimes there's no change in the pressure, so we try a different drop, and maybe now they're allergic to that one. And then they have keratopathy, and then we move from a generic to a name brand drop, and they'll complain about the cost of that, of course. And then there's issues of compliance. Are they really even doing any of the drops that I'm prescribing? And then there's a COVID-19 related loss of follow-up for many patients, and they come back and they're not on any drops now. So then what? We can do laser therapy, of course. In residency, I did argon laser trabeculoplasty, where we make microscopic holes in the trabecular meshwork. There's selective laser trabeculoplasty that's less destructive. Trabecular meshwork is remodeled with that. And then there's the classical continuous wave diode cyclophotocoagulation. There's indirect destruction of the ciliary processes and a reduced aqueous production. In residency, we use this often with end-stage glaucoma, patients with poor visual potential but high pressures and a painful eye, or we're worried that they're going to lose whatever remaining vision they have because their pressure is out of control. There's also endocyclophotocoagulation. It's a similar diode CPC, but there's a probe that's placed into the posterior chamber for direct application of the laser to the ciliary processes, where you get whitening of that tissue for destruction of the aqueous production. And this is often done in combination with cataract extraction or in a pseudophakic patient. Classical continuous wave CPC, you have an initial rise of thermal energy and then a plateau. And the only way that you can really adjust the power is by changing the amplitude of that power and then the exposure duration. And you kind of wait until you hear a pop that tells you that there's tissue destruction, and then you move to another spot. The problem with continuous wave CPC is that there's a lot of adverse effects: iritis, post-op pain, ptysis. And in order to perhaps evolve from that concept of IOP reduction, perhaps we can make it safer by chopping up that thermal energy into shorter pulses with an on and off time that's adjustable, and that's called the duty cycle. This can limit the time for the laser-induced heat to spread to the adjacent tissue. It reduces the damage to the tissue, and it allows cooling to take place before the next pulse. So from that concept of MicroPulse laser, we can provide laser that rapidly switches between energy on and off, and therefore it can be less destructive with less adverse events, lower risk of vision loss, and lower risk of ptysis. The MicroPulse laser has many applications, so the transscleral MicroPulse cyclophotocoagulation, that's what I'm talking about today. There's also MicroPulse laser trabeculoplasty, which is similar to SLT. And then there's MicroPulse laser for retinal disorders like diabetic macular edema, and cystoid macular edema, and that's a lecture given by our retina colleagues. MicroPulseTransscleral laser therapy can be applied through the ciliary body to the processes, but it's safer than continuous wave destructive CPC. This is a model of the Cyclo D6 glaucoma laser system, and this shows an example of a probe here. And rather than destroying the ciliary processes to reduce aqueous production, this laser therapy is minimally destructive, and it's believed to lower your IOP by increasing uveoscleral outflow. Why not go from drops failure to incisional surgery? Well, trabeculoplasty is an option, but there can be a lot of complications post-operatively with high pressures, and you have to laser your flap sutures, ask them to do digital massage. You can have low pressures with choroidals, maculopathy. You give them atropine and time and hope that their pressure comes up. And then there can be leaks, both early stage and even decades later. They can end up with a bleb leak, which is kind of a risk factor for blebitis. Tube shunts, there's valved and non-valved, but both can have low pressures, especially the non-valved if you're not suturing your tube. The valve shunts have less issues, but I have also had choroidals with the Ahmed valve tube shunt, and sometimes they're back on eye drops pretty quickly after the tube shunt. Sometimes within that early post-op period they go over 10, and now they're back on drops. Even worse is the plate fibrosis that can happen early on or even late stage. So even the gold standards of incisional surgery are not foolproof. So in that idea of evolution, we originally began with the MicroPulse P3 probe that was an oval probe, and of course you did a slow sweep 1 millimeter posterior to the limbus. You pointed it towards the optic nerve, and you did a duration of 10 seconds per sweep per quadrant. So that means you start from here and then slowly travel across to here in a duration of 10 seconds. And you do that 4 times for a total of 40 seconds per quadrant. Other surgeons prefer treating by a whole hemisphere, and in that case you would go across one hemisphere in a slow duration of 20 seconds per sweep, and then come back and do that 4 times for a total of 80 seconds per hemisphere. Ergonomics for me and many surgeons favors a quadrant approach, mostly because when you're in a particular quadrant, that limits how much you're having to rotate and allows you to maintain flattening of the probe along the limbus. With the original MicroPulse P3 probe, I'd offer that to any glaucoma patient, even ocular hypertension patients, but it doesn't matter if they're open angle, closed angle, or a secondary glaucoma. They can be at any stage of glaucoma, and you can safely use this laser. Traditionally, I often will use this after exhausting drops options and often after SLT in the office. This can be used, of course, before incisional glaucoma surgery, such as a trab or a tube shunt. And unfortunately, I often have to use this in elderly patients after a failed trab or tube. And sometimes for patients who have had an incisional surgery, they're not doing well, this can buy you some time to reduce their pressure while they're deciding whether they're willing to go out of town, perhaps for a second tube shunt. The issues with the original probe were that because it was oval shaped and you had this notch here, The notch was supposed to allow you to know which way to face that oval probe. But in reality of doing the procedure where you're twisting and turning and then moving to a different quadrant, sometimes you would lose track of which side was supposed to face towards the limbus. The notch kind of hides in the lidocaine jelly sometimes. And so I'd try to use a marker to mark that notch edge, but the plastic is hydrophobic, and then you've got the lidocaine jelly and the mark would just disappear after a few seconds, and then I'd have to kind of look at the probe again and figure out which way to go. So the other thing was you really didn't want to be on the limbus. You wanted to be just behind it at 1 millimeter, but that can be a little bit tricky to maintain that, that distance. Because of its shape, it was technically bulky, and so you couldn't squeeze the probe under the upper lid and have a lid speculum. It would just kind of, it would actually get caught in the speculum a lot of times, and that would bump it into the wrong position while you're trying to sweep slowly. I would actually not use a lid speculum with the original probe. I would just have a Q-tip to kind of hold the lid open and kind of sweep across each quadrant. So what is the trick about MicroPulseTransscleral laser therapy that allows it to be effective? This is going to seem a little bit contradictory to every surgeon's impulse, which is to be a fast surgeon. We want to be like Amar Agarwal, but in reality, the trick of this laser is to slow down. So just a small budge or shuffle of the probe laterally with each second, which is indicated by a ding of the machine, is how you should imagine your movement. And as you're shuffling, there might also be a tiny twist of the probe because you have to maintain the curvature of the limbus. So and the key thing is just listening to the dings to know when to make that budge and to make that small shuffle a tiny shuffle, just half or 1 millimeter per second. So it's really a snail's pace that is required for this to be effective. The good news about MicroPulse TLT is that it's an easy post-op, both for the patient and for the surgeon. Immediately post-laser, I treat them with atropine ointment and Neopolydex. They get a patch. They don't need a shield. They have already received propofol for the procedure, but you may want to give them some fentanyl or ketamine. Otherwise, you may get a call from the PACU saying they're having pain. But usually once they go home, it's uncommon for them to complain of significant pain. There can be some post-op nausea. I have had that in a few different patients, and I'm still not totally sure if it's an anesthesia issue or it's the laser to the ciliary body that's causing that. But I do traditionally give them Zofran IV intraoperatively just to reduce that risk. And rarely, like I said, post-op night 1, I've had a few patients call with nausea, and I've prescribed oral Zofran. They have a quick recovery. They can go back to normal activities pretty much the following day. There's no issues of lifestyle changes. You don't have to worry about picking up or bending over and then having a choroidal. We don't have to worry about ptysis, in the long term with these folks. And the great news is they're not going to show up post-op day 1 or week 1 with an elevated eye pressure. At worst, it'll just be kind of the same as it was pre-op. You don't have to worry about significant vision loss caused by the laser itself, like we did with classical continuous wave CPC. I, of course, check the patients post-op day 1. I keep them on the same glaucoma drops as prior to laser, and I give a prednisolone acetate taper. Another option would be to give them some solumedrol intraoperatively, and then they don't have to necessarily do drops. And then I check them in a week to 3 weeks, depending on how they're doing. Adverse events, there's some mild iritis, but it really is mild. It's even less than, your complicated cataract surgeries in terms of iritis. They don't really have a lot of post-op pain. This was certainly something I was worried about based on my memories of residency and doing CPC on those patients. Those patients had to have Tylenol 3, but I have not actually had to really use that. I just tell them take some over-the-counter ibuprofen or acetaminophen, and that seems to be fine. They're going to have a little bit of redness, injection. The mydriasis can occur based on how close you get to the ciliary nerve at the 3 and 9 o'clock position. But that slowly does go away. And I've also cyclopedged them with atropine ointment, so you're going to have mydriasis for at least a week from that. Post-op nausea I talked about, and then, worst case scenario, there's either a lack of IOP reduction or an insufficient IOP reduction, and so we're going to touch on that topic in a minute. So we all knew that this was working, but perhaps there's room for improvement. Maybe we can get a revised probe. And so here's the original one. And then there should be some photos of the, let's see, there we go. That was cool. I didn't even know that happened. But here's the old probe, and here's the revised probe. And so, awesome, it's asymmetric. We have these bunny ears just pointing in the direction that it needs to go towards the limbus. It's easy to fit under the upper lid, and I can even use a lid speculum now. It was great. Initial recommendation was stick to the slow sweep, 10 seconds per quadrant. Just do 25 seconds per quadrant for the 4 quadrants. So that equated to about 2.5 sweeps across the quadrant. Okay. So sounds like a short treatment. That's what we all said when we got those recommendations. I was excited about the probe, but I think the first cases I did with the new probe, I just really wasn't seeing much of a change in the eye pressure. So we got instructions from the reps to, hey, maybe you should change your duration. Let's go back to the 40 seconds per quadrant perhaps. Stay with the 10 seconds per sweep. Or if you were doing these hemispheres, avoiding the 3 and 9 o'clock, you would do 80 seconds across the hemisphere at 20 seconds per sweep. Still, I think initially I wasn't getting the same IOP reductions that I saw with the previous probe. I also noticed there was less mydriasis, and I had a question in my mind, is there less energy transmission going on? So I think many of us thought maybe it's time for reassessment. We received an email from Iridex saying, hey, it's time for us to do a software upgrade for your unit. As a part of that, we'd like you to participate in a peer-to-peer academy where we can provide some of the newest treatment recommendations. And this was led by leading glaucoma specialists. And the message was, you can safely increase your duration to 50, 60, or even 70 seconds per quadrant, which equates to about 140 seconds per hemisphere. You can also think about increasing your power from the most commonly used 2,500 milliwatts up to 2,700 milliwatts. And then lastly, you can slow your sweep down to maybe even 15 or 20 seconds per sweep per quadrant. The only issue is that's just such a tiny budge in the probe to achieve that. You really have to kind of just go at maybe every 2 seconds and then budge in order to get to that 15, 20 second sweeps per quadrant, because you're really only doing 3 clock hours per quadrant, because the 3 and 9 o'clock you're trying to avoid. The key thing about the new software is that it was going to help manage your sweep velocity. Basically, you can program the number of seconds that you want to achieve for each sweep. You can adjust how many sweeps per quadrant or hemisphere you're going to do. You're still going to do every second that micro shuffle. And then there, instead of a voice telling you 50 seconds, 40 seconds, 30 seconds like before, there were distinct tones to help maintain that sweep velocity, to keep you on track, to know where you should be on the eye and how fast you're going relative to those beeps. Because the reality is you can't really look at the machine and the eye at the same time. So it's really important to have that auditory cue to help you along the treatment, and then it keeps track of how many sweeps you've done for that quadrant or that hemisphere, because you're not going to remember all the time how many did I just do now. So let's see if I can get the video. Okay, so you can hear the beeps. Boom. That's halfway through. Boom, boom. That means you're at the end of that sweep. You need to turn around and go back the other direction. That noise, that's the patient moaning. Which is why you do have to do this in the operating room. You really cannot do this, I don't think, in a clinic environment unless you're willing to do a retrobulbar block in your clinic in the absence of much anesthesia. So, like I said before, these folks are receiving propofol. They will kind of moan sometimes in pain, but they won't remember the pain, and you just kind of have your anesthesiologist adjust their propofol as you go. So I'll do some case examples. Did I skip the slides? So here's a 92-year-old gentleman. He's got severe glaucoma, and his cup to disc, of course, they're already 0.9. He's got a central island vision. I'm on to 10-2s only now. His mean deviation on those 10-2s is -23 and -24. So he's got severe disease. Of course, he's already had a trab in both eyes. And he's been doing fine. You know, his pressures have been in the low teens. He's on 2 drops. And then suddenly he comes in and his right eye's pressure's 34. His vision drops from 20/40 to count fingers. And, you know, this is a really shocking situation. So I add brimonidine and I schedule MicroPulseTransscleral laser therapy right away. He did no show for his pressure check because I wanted to see if the brimonidine was helping. So in the OR, at this point, I'm at 50 seconds per quadrant for 4 quadrants. And then my sweep velocity is still 10 seconds per sweep per quadrant. But of course, if you want to go slower, you can, and that can increase your efficacy while maintaining the same power. So post-op day 1, he's hand motion, but his pressure's better now. And then as you go, post-op week 1, vision's improving, pressure 6, he's getting confused about the drops. So I put him back on all the drops. He's 20/60 at week 3. Pressure's still holding in the single digits. And then post-op week 6, or month 6 actually. Post-op month 6, he's 20/70. So he has lost some vision related to this whole event, but his pressure's under control, and he went from count fingers really back to 20/70. And so this is one of the pearls about MicroPulseTransscleral laser therapy. You can use it quickly to bring down the pressure and maybe in time to recover vision. There's not as much difficulty in counseling the patient about it because it's not as invasive of a surgery as going back for a tube shunt, right? Because he's already had a trab. case example 2. So this is a 75-year-old woman. She's been lost to follow-up for 5 years. So that's pandemic plus a few years prior to that. So she comes in with the cup to disc 0.5 on the right, left eye 0.9. Her visual field for that left eye is a central island. On a 24-2, the mean deviation was -23. She actually has a relative afferent pupillary defect to start with in this eye. So she shows up with a vision in that left eye, 20/50, and her pressure is 34. She hasn't been seen for 5 years, so she's running out of Lumigan, which I'm not sure where she's getting it in the first place. So I go ahead and just get her on latanoprost and dorzolamide timolol. She comes back, she's getting a little bit better. I add some SLT. That helps for a little bit, but then her pressure pops back up. She's now at 33, and she's on latanoprost dorzolamide timolol. I add brimonidine. I'm still at 30. Let's try Vyzulta. She's at 34 on Vyzulta. That didn't really help all that much. Let's try Rocklatan. That's not really helping either. So that's really frustrating. I say, you're going to need some MicroPulse TLT. Hopefully that'll help. So at that point, I'm doing 50 seconds per quadrant at 2,500 milliwatts. And post-op day 1, her vision's a little bit worse, but her pressure's coming down. I have her on 3 glaucoma drops. She can't afford any of the other ones anyways. So then week 1, she's coming down to 20. Week 2, 16. Week 3, 18. I'm doing great. I'm out of the woods. Not so fast. So post-op month 2, pressure's 29. I'm telling her maybe you need to go see a glaucoma specialist a couple hours away. She doesn't want to go. And so finally, at month 3, I say maybe we can retry the MicroPulse. We did have some improvement of pressure. We didn't have full target pressure, but let's try again and maybe adjust the settings. So now I'm going up a little bit on both. That was a little bit aggressive to go up on both. You may want to do one at a time, but I felt like I was losing vision. So I did try this, 60 seconds per quadrant. So that's 6 sweeps per quadrant. And then at day 1, she's 25. And then at week 2, she's at 7. So that's a pretty big drop there. Like I said, you're not going to see the drop necessarily that first day. And that's okay. You just give it some time. So here's the Pearl on that second try. Increase your duration per quadrant or change the power. I think a little bit more tricky may be to change your sweep velocity, because I'm pretty used to that ding and that small budge with the 10-second sweep per quadrant, but you could theoretically use the software to help you achieve a slower velocity and just space your budges a little bit farther apart. So she's a patient that also had post-op nausea the day of surgery, both on the first try and the second try. So I had already given her a paper prescription for Zofran. But it's not a lot of patients who get it. It's just that the reality is there will be some. So I'll end with some pearls. So in the clinic, you can tell the patient this is an easy outpatient laser procedure. It's covered by your insurance. It's going to lower your pressure, but it cannot be done in the office because of pain during the laser. So we'll put you to sleep for about 5 minutes during this laser. It has great coverage because it's an old CPT code. You may want to get PCP clearance if they're in poor health, which is pretty common in advanced glaucoma. They will need to get propofol and during the procedure, and they may need a little bit of fentanyl once they're starting to wake up. Or ketamine is another option if you're worried about respiratory depression from the fentanyl post-procedure. In the OR, so this is a substerile procedure. It's non-incisional, so you don't have to necessarily do a betadine prep. You don't necessarily have to have sterile gloves on. You can just have regular gloves or no gloves, depending on your preference. Tetracaine for sure, and the lidocaine gel prior to the laser. Anesthesia will provide the propofol. Optionally, you can provide a retrobulbar block, but the propofol required for the block is equivalent to the propofol required for the entire procedure in terms of amount. So, and like I said before, there's not a real issue of post-op pain that first day that necessitates a retrobulbar block, and I haven't had to use retrobulbar block for the MicroPulse MP3 laser. It's different from your classical continuous wave laser in terms of pain. You can put in a lid speculum, you put in a copious amount of lidocaine jelly, and that's required for the probe coupling to allow transduction of the diode laser. You can have a cotton swab in your other hand to move the globe for further exposure. Or if you really need to infraduct the eye, you can get a muscle hook to uncover that superior hemisphere. The inferior hemisphere is usually really easy to access. Like I said before, your curved side bunny ears are going to be aligned at the limbus. You're going to be kind of flat and flush to the sclera. And the quadrant approach really helps you kind of maintain that flat and flush to the sclera because you're not moving that far across. And then when you go to a different quadrant, you can switch hands so that you can better maintain that flat and flush to the sclera with the pressure equivalent to writing on a piece of paper with a pen. Remember to avoid the 3 and 9 o'clock positions. You're going to go very slow with a tiny budge with each ding. You do that 10 seconds per sweep per quadrant or 20 seconds per hemisphere. Like I said before, I give atropine ointment. That's optional. I give steroid ointment and then patch them. They go to the PACU, maybe with a little bit of fentanyl and Zofran on board. So post-operatively, like I said before, they're going to stay on the same glaucoma drops initially because you're not going to see a rapid change in the pressure that first day post-op. You're not worried about hypotony in this situation. There's mild iritis, so either pred-acetate or fluoromethylone taper in whatever manner you usually use. You could try to take off a post-op drop or their Diamox tablet at month 1 or month 2 if they're below their target. You can expect mydriasis at least for a week because of the atropine ointment, but sometimes a few weeks after that. And the closer you go to that 3 and 9 o'clock position and the higher your power, the more likely you'll have some mydriasis, but it will go away after a month or so. If after 3 months your IOP reduction is insufficient, you can really try again and enhance your original TLT, perhaps by, like I said, increase your duration or increase your power. So it's an easy procedure with a success rate between 60 and 80%. You've got low risk of adverse events. There's moderate efficacy for IOP reduction in that 30 to 45% range. It can be used to delay the need for incisional glaucoma surgery. It can also be used after failure from their first or second incisional glaucoma surgery without the devastating adverse effects that we know about from classical continuous wave cyclophotocoagulation. And the key thing is it's got universal insurance coverage, unlike some of the MIGS devices, which can be costly and are not covered by some managed care replacement plans. This is a procedure that you can give to your surgery coordinator, and that's going to be approved. And it doesn't have an expensive device per use like other MIGS devices may have. And that's the end of the talk. I really appreciate your time. Thank you for inviting me out here. I love Chicago, and I hope you guys enjoy it.
Thank you so much. Do we have any questions? Yes?
When do you see your patients back after your initial procedure? Like, when do you expect to see an actual pressure reduction?
Yeah, based on the case examples, that post-op day 1, you're going to check them. Their pressure should be about the same as pre-op. And then if their pressure, is a really high concern, I just see them a week later. If they're doing pretty good, 2 weeks is fine. So you don't have to worry too much about pressure spikes right after the laser. And you keep them on the same glaucoma drops until you see the pressure reduction that satisfies you, and then you can try to peel one off. Well, you definitely can see effect by 1, 2, or 3 weeks. Yeah. And then if you don't have sufficient effect by 3 months, then that's when you kind of consider, hey, can I offer this again to the patient, or do I need to go to a MIGS or incisional surgery?
I have a question. You talked about the enhancement at 3 months. Do you have any experience or any view on repeat procedures after a more extended period if pressures start to rise? String together multiple treatments?
Yes, there's definitely many glaucoma surgeons who do this procedure not just twice, but maybe 3 times or 4 times over the course of a year. And if you're seeing incremental improvement, you can continue to use it and feel that it's going to be a safe procedure for them, because I don't think there's an additional risk of irritation, inflammation, uveitis, and CME like you might have if it was the classical continuous wave CPC.
And what are the limits of the time and the power?
What are the limits?
Yes. Can
So
you use
I think that
3,001 minute or?
So, like I said, I think that right now our upper limit for the duration per quadrant is about 70 seconds. I think is where currently we're saying that should be one thing you can modulate. You can then modulate your power to 2,500 all the way up to 2,700, and that's kind of the parameters for that. You kind of can mix a little bit of those two, and then lastly, you can slow down your sweep velocity, and that can also provide you with improved efficacy without increasing your power or duration.
Yes, but are there any studies which show that the more power or more time is dangerous, or is just your experience?
Yeah, these are based on the peer-to-peer academy recommendations for Iridex. I can't say specifically what's been reported in the literature in terms of upper limits of the power. I'm not sure about that one.
Thank you.
Mm-hmm.
Any other questions? Yes?
Hold it. Oh, sorry. I kind of walked in halfway through. I'm so sorry. But I was just wondering, do you have the new settings that are recommended? You have a slide on that?
Yeah. Let me see here.
Because I think there was just a recent article that came out.
We can also provide that for her.
Yeah, we can definitely get that printed out for you too. Let's see if I can. Okay, so these were kind of the summary of the peer-to-peer academy training session. Like I said before, these are the 3 things that you can modulate to help your efficacy. Is that helpful?